chemotherapy in general. I will be talking a little bit about lymphoma, so there will be an emphasis on lymphoma. Principally because that is by some margin the most common type of cancer that we use chemotherapy for. So we're going to be first of all talking about the goals of treatment and some definitions regarding approach to cancer therapy. Then we're going to be talking about various chemo drugs and protocols we can use specifically for lymphoma, what we're going to expect in terms of prognostic indicators. Also a little aside about how in dogs in particular, we can have patients with lymphoma in some instances remaining happy and healthy for 3 years or longer without any form of chemotherapy whatsoever, and how to recognize those patients where chemotherapy may be inappropriate, even though they do have lymphoma. Then we're going to be having a section on troubleshooting chemotherapy, and that's in terms of what can go wrong in terms of side effects, how to identify patients with various disease sets where chemo may not be such a good idea, or certainly specific chemo drugs may not be so good. And then lastly, we're going to talk a little bit about what's new in terms of some drugs that are quite new in the market that are specific for lymphoma in dogs. So to begin with, just so we're all very clear what we're talking about, what chemotherapy is the administration of drugs with a narrow safety margin to a patient that's almost inevitably going to die of its illness anyway, no matter what we do. And that, you may feel, is somewhat pessimistic, but it is also very, very true. And so therefore, first and foremost, we've got to, if that is the case, and it is with almost all dogs and cats with lymphoma, that statement is true. So how do we justify the use of chemotherapy in the first place? And it has to be used always with the aim to promote and maintain quality of life. So that is absolutely paramount. And if we cannot achieve that, maintenance of a good quality of life, we shouldn't be using chemotherapy. As a secondary aim, and only a secondary aim, is to maintain that quality of life for as long as possible. And these are some sort of rough figures in terms of what we would aim for in terms of survival and response to therapy in dogs and cats with lymphoma. And you will have seen these figures in other texts as well. So in dogs with what we term a high-grade lymphoma, about 85% to 90% of dogs will go into complete remission. By that I mean a complete disappearance of all obvious signs of lymphoma, and overall we'll be able to achieve that for about 10 to 12 months of survival. Cats have a lesser incidence of remission of about 60 to 70%, but, and we'll come on to this later on, prolonged survival of 2 years plus is not common, but certainly more common in cats with lymphoma than it is in dogs. So I like this slide because I like this picture, because that dog is lying there and he's saying to myself, in about 5 minutes time, somebody here is going to lose a finger and it ain't going to be me. But in terms of the terminology regarding approach to cancer, then we talk about staging, which is the evaluation of the extent of the tumor, and we do that in lymphoma via our diagnostic imaging, and we pay attention to it because it has an effect on prognosis, as we'll see. Whereabouts in the body the lymphoma actually does have an impact on prognosis. It may guide our therapeutic intervention, as we'll come on to in subsequent slides, and it may also be of help in monitoring response to treatment. We talk about tumor grade as we do in any cancer, and lymphoma is no different to that. We have our intermediate to high grade lymphoma, and we tend to group, you'll often see in reports, pathologists talk about intermediate and high grade lymphoma. We tend to bunch those two grades together because they respond to treatment in very similar ways. They have a very similar prognosis. We treat them just the same. So intermediate or high-grade lymphoma usually comprise of relatively immature lymphoblasts that are rapidly dividing. And as you know, This behaves in quite an aggressive fashion, so it spreads quite quickly. If left untreated, it will prove fatal within a few weeks to months. But on the other hand, it responds to therapy, chemotherapy, initially at least, generally very well. And these are the bunch of dogs where we get 80 to 85 to 90% of them going into remission in response to chemotherapy. Now, low-grade lymphoma is quite a different beast. It's comprised of relatively mature cells, in this case lymphocytes, and these are more slowly dividing, and as a consequence, this is more of a slowly progressive disease, and sometimes very slowly. Sometimes this disease will progress over years. So it is sometimes, in some dogs in particular, a very slowly progressive disease. As such, it also responds relatively poorly to chemotherapy, at least initially. It takes some time to knock this low-grade lymphoma on the head, but if it does respond, it often stays responsive to chemotherapy for quite some time. And we see this in our cats with low-grade alimentary lymphoma. We'll come on to this later on in the talk. We also, so specifically with lymphoma, we talk about immunophenotype as to whether it's a B lymphocyte lymphoma or a T lymphocyte lymphoma. And this is usually worth establishing at the time of diagnosis. If the cellular yield is high enough, most labs can run this, can run immunocytochemistry on an air-dried smear. So we don't necessarily have to take more samples for this. We know that in dogs with high-grade lymphoma, T-cell immunophenotype tends to respond not as well as a B-cell immunophenotype. That holds true for high-grade lymphoma, but not necessarily, as we will see with low-grade lymphoma. It may have an impact in terms of what drugs we use when a patient has a relapse. In terms of for the T-cell lymphomas, we tend to sometimes reach for drugs like lomustine more so than we would go for with perhaps a B-cell lymphoma. So that's the treatment and aims and definitions. And now we're going to go on and talk a lot more in terms of the nitty-gritty as to how we treat this. What sort of drugs do we use? What do we expect in response to these drug therapies? What are our options? And also when we should perhaps not treat, but watch and wait. So very generally, we've got three treatment options when it comes to lymphoma. We have local therapy, which is rarely employed, but we will see there are some indications where local therapy, and by that I mean either radiation or surgery, is potentially useful. The vast majority of these tumors will be treated with some form of chemotherapy. And lastly, we have the option of no therapy at all. In terms of local therapy, as we said, our options are in that regard surgery or radiation. Obviously, it only applies for disease that's not widespread. And the examples of specific to lymphoma where we might look at local therapy would be nasal lymphoma. It is quite exquisitely sensitive to radiation, but that said, because of the relative paucity of radiation facilities, we'll still treat the majority of nasal lymphomas with chemotherapy. And we'll see how there are some specific indications for surgery in particularly dogs with some forms of low-grade lymphoma. And in terms of the types of chemotherapy we will employ to treat this for our high or intermediate grade lymphoma, which is the one where we've got a very rapidly dividing population of cells, we'll use our sort of traditional chemotherapy, which is a maximal tolerated dose approach, where we'll use one or a variety of drugs given at the maximum dose that we can give without causing unacceptable side effects, and giving that dose as frequently as possible. We will have then our low-grade lymphoma. As we said, this is slowly progressive, slowly responsive to chemotherapy. Maximal tolerated dose chemotherapy does not work particularly well in this against these slowly dividing cells. Instead, we'll use long-term low-dose medication given very frequently, and that's something that's referred to as metronomic chemotherapy. And it probably works in slightly different ways to our traditional maximal tolerated dose chemo. So what's in the name? What does this maximal tolerated dose actually mean? Well, this is obviously a graph looking at what happens to populations of cells exposed to maximal tolerated dose chemo over time. The green line is our normal cells that are affected by chemotherapy, and these could be our bone marrow cells, it could be the gut or intestinal epithelium, and then the red graph or the red line represents what happens to the tumor cells. Now, what maximal tolerated dose chemotherapy actually does is it takes advantage of the notion that tumor cells of any description, and we're talking here about lymphoma, this applies to any tumor, that these tumor cells are inherently not as good at repairing themselves in comparison to our normal body cells. So that when we use maximal tolerated dose, as we can see over time with successive doses of the drug, the tumor cell population never recovers fully, but takes an additional hit. And so we see an incremental decline of the total tumor cell numbers over time, whereas our normal body cells, yes, they do have peaks and troughs, but overall their population remains fairly stable. And what we're trying to do is just that, to kill the tumor cells over time, by using high enough doses of a drug to do that, but not so high that normal healthy body cells are also deplete over time, leading to unacceptable side effects. And that's the balance, and that's where maximal tolerated dose, where that name comes from. And I first wrote this talk about 20 years ago, and it is fair to say that I have had to modify almost every slide in the talk between then and now over time. The one area where I've had to do very little, if any, modification over time is on the maximal tolerated dose chemotherapy that we use to treat high or intermediate grade tumor. And that's a little bit disappointing because it reflects the lack of progress that we've been able to achieve over time in terms of treatment efficacy. Now, in our last slide, we will come on to some new drugs that do hold some promise. But that aside, there is a school of thought that says we have probably come as far as we are going to come using, if you like, conventional chemotherapy drugs given on a maximal tolerated dose basis. So obviously the things that influence our choice of protocol are the evidence available in terms of what's the most efficacious, and there are some differences between dogs and cats in that regard. The presence of concurrent illness that may limit our use of specific drugs, and we'll come on to talk about that aspect of things when we talk about troubleshooting chemotherapy. So what do we know? Well, we know that for high-grade lymphoma, single-agent chemotherapy probably isn't as good as multi-drug protocols. We know that prednisolone will usually afford a survival time of a few weeks to maybe a month or two. Doxorubicin used as a single agent with or without prednisolone, usually with prednisolone in dogs, usually will get sort of a 60–70%, if you like, response rate in terms of the dogs going into remission, and a 5 to 7 month survival. Now, it is important to note that this is a dog-centric protocol. Doxorubicin monotherapy does not, cats do not respond as well to that. And as a general rule, doxorubicin tends to be more effective as a treatment in canine rather than feline lymphoma. So moving on to our multi-drug protocols, then our options are really the very traditional COP-based protocol, which is cyclophosphamide. The O stands for oncovin, which is vincristine, the P for prednisolone, versus our doxorubicin-based protocols. And The doxorubicin-based protocols, such as the CHOP protocol that uses basically a good way of looking at CHOP protocol is it's COP plus doxorubicin, okay? But the other big difference between the CHOP-based protocol is that the CHOP-based protocol is discontinuous. By that I mean we treat for a certain specific length of time, and if the animal's in remission at the end of that treatment time, usually about 6 months, we stop and then monitor for any relapse thereafter. And that's the big advantage of, or one of the big advantages of the CHOP-based protocol. For us and the client and the patient, there is an end in sight. We're going to treat for this duration, provided everything's going okay, but after that, we're going to stop. Whereas the continuous protocols, which is the COP-based protocol, they tend to run and run and run and run for potentially years because and there isn't necessarily an end in sight with that. Now, we know that in dogs, inclusion of doxorubicin tends to improve survival, improves response. But the same isn't necessarily true in cats, where the COP protocol and the CHOP protocol are probably equally efficacious. So a lot comes down to, in particular in cats, what the client preference is. But also, and I think this is something that's often overlooked in chemotherapy, is that if, as clinicians, we get good at using things that we use a lot of, and we're not as good, generally speaking, at using stuff that we don't use very often. That's just human nature. It's nothing to do with veterinary medicine. But it does also apply to chemotherapy drugs. And I think for us as a team that give chemotherapy to patients, our response rates, our successes are generally much higher if we try as much as we can to limit the chemotherapy protocols we're using, rather than having, say, 3 patients and 3 different protocols, because that's where confusion lies, that's where mistakes can sometimes happen. Whereas 3 patients on the same protocol, not that that's ever going to be necessarily achievable, but as something to aim for, then that maintains uniformity, maintains consistency, which in turn limits the capacity for errors, and our success rates tend to be higher as a consequence. So our preference also factors into what choice of chemotherapy protocol we're going to use, and that also comes to play in terms of what drugs we are maybe comfortable handling versus not so much. So in terms of facts and figures, we've seen this in a previous slide, and what are we going to try to achieve in terms of response to chemotherapy for dogs with high-grade lymphoma? 80 to 90% remission, 10 to 12 months survival time. That's typically for a high-grade B-cell lymphoma, less so for a T-cell lymphoma. 10% alive at 24 months. Those are the lucky few, because the vast majority of dogs don't make it that long, unfortunately. And one of the things that are therefore going to adversely impact our chances of achieving those figures, and these are the prognostic factors that feed into our sort of forecast, if you like, of how likely or how much success we're going to achieve with the chemotherapy. We know that for high-grade lymphoma, T-cell lymphomas don't respond as well or as long as B-cell lymphomas. We know that for all dogs with lymphoma, those dogs that are systemically unwell as a consequence of their lymphoma, so-called substage B, tend not to do as well as those dogs that are systemically well, that simply have great lymph nodes the size of grapefruits. Those dogs are substage A. Now, anatomic location has an effect on prognosis as well. And so we know that dogs with hepatic lymphoma, primary GI lymphoma often don't do very well with oftentimes survival or response rates, or response duration, should I say, of about 30 days or less. We know that dogs with advanced stage lymphoma, where there's bone marrow involvement, also often don't respond as well as we'd like. Dogs with CNS involvement, mediastinal involvement, diffuse skin involvement, so-called epitheliotrophic T-cell lymphoma, tend not to do as well. And that list is extensive enough as to be rather unhelpful. One thing that does come through is that dogs, with the possible exception of nasal lymphoma, that have extranodal involvement, i.e. the lymphoma is in other areas other than lymph nodes, commonly do not do quite as well as those dogs that have our traditionally recognized form of lymphoma, which is the multicentric lymphoma, there, where it's largely confined to lymph nodes plus or minus a spleen as well. We know dogs that are anemic on presentation tend not to do as well in response to chemotherapy, and those dogs that have received prior steroid treatment, because what those steroids do over time, and nobody quite knows how long it takes for this to happen, but if a dog's on steroid therapy, then what those lymphoma cells gain as a result of steroid therapy is they have increased expression of a transmembrane pump that unfortunately works by actively exporting chemo drugs from the inside of the cell to outside the cell, where obviously they're not going to work. So prior steroid treatment will decrease response rates very often from 85% down to about 50%. And that's in dogs and in cats, as we said, you know, the generally speaking, for cats with high-grade lymphoma, their remission rates are less than dogs, about 60 to 70%, and then survival times of about 4 to 6 months. I would often say maybe slightly longer, 7 months or so, but generally not as long as in dogs. And then another quite old study published over 20 years ago, looking at cats with a COP-based protocol, 75% complete remission, 12-month survival, about 50%. So 1 in 2, 1 in 2 cats that were on this therapy were still alive at 12 months. That's less than we tend to expect with dogs. But the interesting thing then is the percentage of cats was alive at 24 months, 2 years in, about 40% of them were. So the drop off from the cats that were still alive 12 months post commencement of the protocol to the number that were alive at 2 years is relatively small. So there are some cats out there that respond really well to chemotherapy initially and sort of stay responded. And what we don't know, and what we don't really understand is what the specific variables are that pertain to that, you know, population of cats that's still alive 24 months out from starting chemotherapy. So what are the things that affect our expectation, if you like, that we're going to achieve those figures? So what are the negative prognostic factors? Well, FELV status is 1, so cats that are FELV positive tend not to respond as well to chemotherapy. And obviously the cats that have a complete remission in response to treatment tend to do better than those that don't. That's only something we can evaluate after we start giving the chemotherapy. Anatomic site is also a prognostic indicator. So cats that have a high-grade elementary lymphoma, and particularly those that have a variant of this called a large granular lymphoma, really don't do very well in response to treatment, with sort of survival times of about 40 to 50 days, although some will do better for longer. Cats that have CNS involvement tend not to do as well, and cats that have renal involvement, again, tend not to do as well. Part of the reason for that is that renal lymphoma very often also involves the extradural space. So in that sense, it also has a CNS involvement as well. And now moving on, that's all to do with high-grade lymphoma. Now we're going to go and talk about something that's a little bit different, and this is a low-grade lymphoma. So these are the lymphocytes, the mature cells that are dividing relatively slowly. And this type of lymphoma tends not to respond very well to our maximal tolerated dose chemotherapy. Instead, we adopt a gentler approach, if you like, where we use much lower doses of drugs given very frequently over a long period of time. And generally speaking, we'll use things like prednisolone and chlorambucil in combination. And one of the more common types of low-grade lymphoma in cats is this low-grade alimentary lymphoma. And it's relatively common amongst the types of GI lymphoma, so much more common, thankfully, than the high-grade alimentary lymphoma, which, as you know, does not respond very well to chemotherapy in most cats. But low-grade alimentary lymphoma does, and it's also worthwhile pointing out, actually, this is a T-cell lymphoma. It's not a B-cell lymphoma. And about 60 or 70% of cats with low-grade alimentary lymphoma will achieve a complete remission and mean survival of about 2 years. So again, although it's a bit of a slow burn in terms of how we treat it, if cats do respond, they often stay responded for a long period of time. And low-grade lymphoma also occurs in dogs, although less frequently than in cats. And there are several forms of low-grade lymphoma in dogs. There's a T-zone lymphoma, and again, this is a T-cell lymphoma. Typically involves lymph nodes. And so we'll see these dogs presenting with peripheral lymphadenopathy. We also have a splenic marginal zone lymphoma. That's a B-cell lymphoma, and usually presents as a splenic mass. And these dogs are often very, very well. They've got big lymph nodes or they've got a splenic mass, but they're seemingly otherwise unaffected. And in terms of treatment, we know that the splenic marginal zone lymphoma dogs will often do better following splenectomy. But there is very, very little evidence for chemotherapy to be effective in this type of lymphoma. And so for that reason, we often, if dogs are systemically well, and provided they're not developing a progressively worsening lymphocytosis or cytopenias, very often we'll just monitor these dogs. And they will often do very, very well without any chemotherapy and potentially following splenectomy for the splenic marginal zone lymphomas for 1 to 3 years plus without any further intervention. Now, some dogs will become unwell as a consequence of their lymphoma. Some dogs will develop cytopenias or progressive lymphocytosis. And in those dogs, we will consider this chemotherapy very often with, as we described for cats, a combination of prednisolone and chlorambucil. So in some instances, rare as the case may be, but in some instances, less is more in terms of whether we intervene with chemotherapy or not. And this is particularly the case in these dogs with low-grade lymphoma. There is a sting in the tail, and that's with a nodal marginal zone lymphoma. So this is like the splenic marginal zone lymphoma. This is involving peripheral lymph nodes, and that, although it's a low-grade lymphoma, tends to be a bit more aggressive, with a sort of progression-free interval of about 5 to 6 months until it starts causing clinical signs. So for that particular presentation of lymphoma, we will often intervene sooner with our prednisolone chlorambucil chemotherapy. So in terms of this metronomic chemotherapy that we talked about in treatment of low-grade lymphoma, as it sort of alluded to earlier on, it may work in a slightly different way to our maximal tolerated dose chemotherapy. So maximal tolerated dose chemotherapy is all about killing the tumor cells. It ends there. We're just about killing tumor cells. That's what we're focused on. Whereas a metronomic chemotherapy, remember, we're using it to target a slowly dividing population of cells that isn't growing all that quickly. But instead, very often these tumors have a very rich blood supply, and this metronomic chemotherapy may actually interfere with formation of those blood vessels, so starves the tumor of the oxygen and nutrients that it needs to grow. There are some studies showing that actually metronomic chemotherapy can alter host immune responses, and that may actually code for an anti-tumor effect. And of course, these drugs that are cytotoxic drugs will have a direct anti-tumor effect. But it's important to realize that metronomic chemotherapy works in slightly different ways to a maximum tolerated dose chemotherapy. And the other reason I'm mentioning metronomic chemotherapy is not just in the context of lymphoma, but it's been looked at and is being looked at as a potential treatment tool for a variety of other cancers as well. So I mention it with a sense of watch this space as well. This is something that we may be hearing more about in months and years to come. Okay, so the next thing we're going to talk about is troubleshooting chemotherapy. And things we're going to talk about is GI toxicity, neutropenia, our approach to chemotherapy in a dog with a heart murmur, cystitis and nephrotoxicity in general, and lastly, what we do about relapse of lymphoma. So GI toxicity, and I mean, these toxicities are pertinent to any tumor that we're using chemotherapy to treat. So usually 24 to 72 hours following chemotherapy, very often you've seen this as many times as I have, I'm sure that patients will just be a little bit off color, they may go off their food, they may actually have vomiting and diarrhea. When we start chemotherapy, I almost always send clients home with some Serenia to use on an as-needed basis. That if they notice a drop-off in appetite or lethargy, they just preemptively start with Serenia. And always bear in mind as well that when you start treatment, and this is particularly when the tumor burden is rather high and you're expecting, as is the case of a high-grade lymphoma, to start killing off a hell of a lot of those cells very, very quickly, that can also cause a lot of inflammation, and that can make these patients feel rather rotten as well. So it's not uncommon when you start out with chemotherapy, particularly for lymphoma, that the side effects may actually be rather worse after the first 1 or 2 treatments, because that's when you're killing off the bulk of the tumor, and there is an inflammatory response associated with that that can make patients feel unwell. So again, for dogs, having maybe some paracetamol at least at hand, if not on board, can be very useful as well for that. Neutropenia, we will usually see this peak bone marrow suppression around 5 to 7 days post-chemo. The exceptions to this are carboplatin and lomustine, where we can sometimes see delayed neutropenia occurring up to 21 days or 3 weeks following treatment. And the other thing, obviously, that we're conscious of about neutropenia is the risk of infection, because this effectively is immune suppression. And there is an exponential increase in the risk of sepsis as neutrophil count drops down below normal, and that then therefore means that patients that are moderately to markedly neutropenic, account less than 1.5 times 10 to the power 9, really are at some considerable risk of infection. And we will prophylactically use antibiotics if the count is going that low, as well as suspending chemotherapy. And the antibiotic choice will be something that's fairly broad spectrum, but it's got to have a reasonably good efficacy against gram-negatives, because that's the most common type of bacteria implicated in sepsis. Now, your cephalosporins or potentiated amoxicillin, absolutely fine, very good choices in that regard. Tend to try to keep neutropenic patients out of hospital unless absolutely necessary, unless they're actually sick and febrile, and they need to come in and go on fluids and IV antibiotics and all of that. But otherwise, if you're immunocompromised, you probably don't want to be in hospital unless you absolutely have to be, because of the risk of picking up infection. So this is kind of how it looks like in terms of our responses to neutropenia. So a count above 1.5, but slightly below normal, which is about 3 times 10 to the power 9 liter. If they're not febrile, not showing any clinical signs, then we'll simply monitor. Probably delay treatment, but I will take a nuanced approach to that. So if say the patient has a neutrophil count of 2.5 or over, and I think that because they're at an early stage of treatment, or because the tumor is coming out of remission, but in any case, I think that delaying treatment is going to have an adverse effect, because the tumor is going to get out of control, then I may decide that actually with a count of 2.5 or over, even though they're neutropenic, further treatment is warranted at that stage. If they're febrile, got clinical signs, then absolutely treatment delay, antibiotics, and close monitoring. For more marked neutropenia less than 1.5, again, if they're not got any clinical signs of sepsis, then antibiotics and treatment delay. But for those patients that are sick and are severely neutropenic, they're the ones where we do probably need to consider bringing them in. They need intravenous fluids, other supportive care, and antibiotics as well. So another cytopenia that we'll sometimes see is a low platelet count. And there's a variety of drugs that we will see this in response to, such as most commonly and most severely lomustine and melphalan. We'll see it sometimes in response to carboplatin, dacarbazine, which we hardly ever use. Doxorubicin can cause a mild thrombocytopenia as well. But in variance to the situation with carbo and doxorubicin, where the neutrophil count or the platelet count bounces back up quite quickly, lomustine and melphalan are associated with a cumulative and sometimes irreversible thrombocytopenia. So if we're using those drugs and we note that the platelet count is dipping less than 100 by 10 to the power 9, we just stop those drugs at that point and switch to an alternative. And implicit in that is we've got to be reasonably good at counting platelets, which we can see here in a blood smear. They're surrounded by green circles. And we've got to be aware of the risk of platelet clumping that we'll see in a feathered edge of a smear, causing an artificially low platelet count on an automated analyzer. The other decision making that we'll have to do about what drugs and when is for these patients and dogs particularly that have a heart murmur, where we're considering whether or not to give them doxorubicin or not. And doxorubicin cardiomyopathy is a real thing where over time and given enough doses, there is a cumulative cardiomyopathy that resembles dilated cardiomyopathy and that can occur in dogs. To be fair, it is rare in dogs that receive a cumulative dose of less than 240 mg per meter squared. And most of our protocols involving doxorubicin typically involve about 5 rounds at 30 mg per meter squared. So your total cumulative dose is usually around 150 to 180 mg per meter squared. So most dogs operate well within the risk of this doxorubicin cardiomyopathy developing. However, the dogs that are at particular risk are those that have some pre-existing cardiac disease, and especially those dogs that are at risk or have a breed predisposition to cardiomyopathy. So these are our St. Bernards, our Dobies, our Boxers, our Cocker Spaniels that have a genetic predisposition to dilated cardiomyopathy. So I treat a murmur in those breeds of dogs as being potentially really significant, and I would try to screen those dogs for presence of cardiomyopathy before I ever use doxorubicin. We can do that by measuring N-terminal proBNP, ideally via echocardiography, but NT-proBNP is an acceptable substitute if echo isn't available. In terms of monitoring the potential development of cardiac remodeling and loss of and the development of doxorubicin cardiomyopathy in patients receiving doxorubicin, then actually an increase in troponin I concentrations very often precedes echocardiographic evidence of cardiomyopathy developing, so can serve as an early warning. Now, do I use troponin in every dog getting doxorubicin? Absolutely not. I would use it in dogs where they have a heart murmur. I would particularly pay attention to using it in dogs where they have a breed predisposition to cardiomyopathy. And we do have alternatives to using doxorubicin as well. We can use epirubicin or mitoxantrone, which are anthracycline antibiotics, so they're in the same class of chemo drugs as doxorubicin, but they have a much lesser effect in terms of an ability to cause cardiomyopathy. Or we can simply avoid that class of drugs altogether. Now, one might argue, saying, well, I've got these drugs here that are the same class as doxorubicin, right? But they're at much lesser risk of causing cardiomyopathy. Why don't we just ditch doxorubicin and use epirubicin or mitoxantrone instead? I mean, they're not any more expensive. But the reason we tend not to is that the reason why doxorubicin causes cardiomyopathy is, we think, it revolves around production of free radicals that damage the cardiac myocytes, but that's also one of the mechanisms by which doxorubicin kills tumor cells. So actually, by switching to a less cardiotoxic drug in the same class, we might be also diminishing our efficacy against the cancer that we're using this drug to try to treat. So that's why doxorubicin, despite the risk of cardiomyopathy, is still used a lot in human medicine as well as veterinary medicine. So we're not quite done with doxorubicin yet, because it also crops up when we talk about nephrotoxicants, chemo drugs, and kidney disease. Now, the main players on this particular stage are drugs that we don't use very much anymore, and that's cisplatin, ifosfamide, which is belongs to the same family of drugs as cyclophosphamide, and a drug called streptozotocin. And then these drugs are all pretty nasty drugs, and they do cause kidney damage. When we used them, which was years and years ago now, we used to have patients on a saline diuresis for about 4 hours pre the drug and 3 or 4 hours post the drug, when the animal was pissing out cytotoxic drug left, right, and center. It was just a bit of a nightmare, to be honest. Not only was it a huge faff, it was also a health and safety issue as well. So we tend, for many, that's one of the reasons why we don't use cisplatin anymore. And instead we use another drug related to cisplatin. It's another platinum compound called carboplatin, which is not nephrotoxic. So we don't have to worry about diuresis with carboplatin. But as we said, we weren't quite fully done with doxorubicin because it is a nephrotoxicant, although not in dogs, but it is in cats. And there is, just as doxorubicin causes a cumulative cardiomyopathy over time in dogs, the same effect on cats' kidneys. It's a cumulative nephrotoxicant. Now, there are some papers out there showing that you can give doxorubicin to cats with early stage renal insufficiency, and provided you monitor them for progression of their kidney disease, you will often get away with it, and doxorubicin won't cause progression of kidney disease. However, we've also got to weigh that up against, certainly in terms of lymphoma, doxorubicin is not as effective in cats as it is in dogs. So I tend to avoid doxorubicin full stop in cats with any form of chronic kidney disease. But that's just my personal view. Staying on the urinary system, then something else that we look out for is hemorrhagic cystitis, and there are two reasons why dogs on chemotherapy can develop cystitis. One is as a consequence of immunosuppression, leading to an ascending infection, and the other is the effect that cyclophosphamide and also ifosfamide, which is a related drug that we don't really use at all, so it's mainly cyclophosphamide, the effect that can have on the bladder. And what this involves is cyclophosphamide being metabolized to something called acrolein. Acrolein is, as I said, a metabolite of cyclophosphamide. It's very, very toxic for the bladder epithelium, and it can cause an erosive cystitis resulting in hemorrhage, and it's so-called sterile hemorrhagic cystitis, and that can be an absolute nightmare to treat, to the point where sometimes it just does not go away at all. So we can't ignore this, and we do monitor any dog on cyclophosphamide, further development of this sterile hemorrhagic cystitis. And ideally, we want to catch it before they start peeing frank blood, because at that point it's a bugger to treat and it may not go away at all. So we really focus on looking for microscopic hematuria. So I typically ask owners to bring in a free catch urine sample at the chemo appointment prior to the cyclophosphamide, so I've got time to look at the dipstick, and if there is blood there, time to run a culture, and if there isn't any evidence of infection, then time to schedule another chemotherapy drug other than cyclophosphamide for when cyclophosphamide would otherwise be due. The other things that we do apart from surveillance for development of microscopic hematuria in any patient in cyclophosphamide is give the dog a chance to pee out that metabolite called acrolein that causes the hemorrhagic cystitis. So give the drug in the morning, so rather than last thing in the evening, so they spend the rest of the day hopefully peeing that drug out, and give it with a diuretic. So if a dog is already polyuric and polydipsic as in response to prednisolone, then I won't worry about using any other diuretic, but if they're not, I will use it with furosemide as well. Either a one-off injection or with tablets given twice a day for 1 or 2 days with the owner to give at home. There's no one furosemide protocol that's been proven to be more effective than the other. Usually I will just use a single injection at the time they have the cyclophosphamide. If we do get sterile hemorrhagic cystitis, then it's often quite painful. And as a result, we'll see spasm of the detrusor muscle resulting in inappropriate urination. So we'll try to combat that pain with non-steroidals plus or minus other analgesics if necessary. Oxybutynin, which is an antimuscarinic drug, can sometimes be helpful at reducing that spontaneous spasm of the detrusor muscle. Glycosaminoglycans is a non-specific promoter of bladder epithelial health, and avoid cyclophosphamide like the plague. Once this has happened, you keep giving cyclophosphamide, it will be irreversible. Now, although cyclophosphamide can cause sterile hemorrhagic cystitis, chlorambucil, which is another alkylating agent, so a similar drug, does not cause hemorrhagic cystitis, so it doesn't give rise to acrolein, so it's an acceptable substitute for cyclophosphamide in most multi-agent chemotherapy protocols. And so comes on to the inevitability of a patient having a relapse. And at this point, we are playing for time, because if the owner keeps going with chemotherapy, we will come to a point where we simply run out of effective drugs to use. So that clock starts ticking at the time the patient has a relapse. So what do we do? Well, if they finished chemotherapy protocol and they've been off chemotherapy for long enough that we feel that the relapse may be susceptible to starting the same protocol again, that's roughly sort of 2 months, give or take, then we will start with the same protocol all over again. We may want to consider using asparaginase as a single dose, because that's quite an effective drug for lymphoma, so it often sort of gives us an added boost in terms of getting the patient into remission. Remember, every time we go with another round of chemotherapy, these tumor cells are going to be more and more resistant, so our response rates in terms of percentage remission, duration of remission, really do fall off a cliff, as we'll see in subsequent slides. If they're still on chemo drugs at the time they relapse, then we've got to change the drug up. So if they're not already receiving doxorubicin, be they dog or cat, we'll usually change to a doxorubicin-based protocol. We can use completely different protocols, and there's a massive number of different protocols. They've all got these cool acronyms. They're all pretty much as effective as any other. So you can either pick the acronym that you most like, or pick the drugs that you are most familiar with, which is probably a more common sense approach. But we often use something called a DMAC protocol, which is a drug called actinomycin D, melphalan, cytosine, and dexamethasone. The reason I use that is because very often by the time you get to relapse, then the patient's veins are pretty shot. And the good thing about a DMAC protocol is only one of the drugs really needs to be given IV, and that's the actinomycin D. The others can be given either subcut or orally, which I feel is a bit of a nice thing. And there are some new alternatives we'll come on to in subsequent slides. But as I said, there are dozens of different rescue protocols. They differ according to the drugs and the acronyms that they're referred to by, but they have some commonality, and that is there is no one chemo rescue protocol for lymphoma that is more effective than any others. They are all very similar in terms of the response rates, and look at the difference in comparison to our initial response rates, where we're talking about, 85, 90% response, and that's way down at 40 to 60%, so about half of all dogs showing response or getting into remission, and the duration of response. Here we've gone from like a year to 1 to 3 months. Okay, so and that's because by the time they relapse, these tumor cells are innately resistant to chemotherapy drugs. And that's why our response rates are much, much less second or third time round than they would have been first time round. Okay, last thing we are going to talk about is some new developments in terms of new drugs that are out there now for canine lymphoma, which you may or may not already be aware of. And the first of these two drugs is verdinexor, or Laverdia, and its full name is Laverdia CA1, and that CA stands for conditional approval, because that's all it's got from the US FDA at the moment, conditional approval as a novel chemotherapy agent for dogs with lymphoma. And this belongs to a group of drugs that we as vets have never used. And the group of drugs is selective inhibitors of nuclear export. And basically, this is all about a group of proteins called tumor suppressor proteins. And what these proteins do is they lurk around in the nucleus of the tumor cell, and they recognize defects in DNA. And as they recognize those defects in DNA, they will trigger apoptosis, which is programmed cell death. So basically, they'll say, right, tumor in that tumor, the DNA of that tumor cell ain't right, so we're going to trigger death of that cell. Now, in order to combat that, what tumor cells do is they develop a series of pumps and other proteins that export these tumor suppressor proteins out of the nucleus and into the cytoplasm, where they simply can't work. Okay, and that's one of the ways in which tumor cells prolong their survival. So, and what Laverdia does is it blocks the tumor's ability to export those tumor suppressor proteins out of the nucleus. It's given as a tablet, which is a bit of a bonus. It's given, that's the dose, 1.5 mg per kg, either 2 or 3 times weekly, depending on the size of the patient, and because there are different size tablets as well. In our initial studies are a little bit, I've got to say, underwhelming. You can see it there in the slides. Dogs with B and T cell lymphoma, 34% response with a time to progression of 17 days. So you're like 2.5 weeks and only a third of patients responding. Not a great sell. There are a population of dogs that respond and stay responded for a little bit longer. So 30% will have a time to progression in excess of about 2 months. One of the things that is interesting about this drug is that it works in an entirely novel way. Like, we've never used this group of drugs before. So that 34% response applies to dogs that have never had chemo and dogs that have had conventional chemo. Because this drug works in an entirely novel way, the tumor cells won't have gained resistance to this, and so the response rates for first up treatment or rescue treatment tend to be very similar. What this drug may be a little bit better at doing is treating T-cell lymphoma, because there's a few studies out looking at this drug used in epitheliotropic T-cell lymphoma, which is a bit of a bugger to treat, if I'm honest. Response rates are reasonable and certainly comparable with most other drugs that we would use as well. So that is something that needs a lot of further study, but it's a glimmer of hope anyway. And it's interesting, therefore, where DiCRA, who are the manufacturers, are positioning or seem to be positioning this drug in the market. Because what they're not doing, and what they can't do with those sorts of figures we saw on the previous slide, is they can't really pitch this drug against conventional chemotherapy for lymphoma and say, yeah, this is definitely like on a head-to-head basis, this is going to be competitive. It doesn't seem that it is. So what they're saying is, or what they seem to be saying, and this is the message coming out of the States, so it may be different once it's from in the European side, but what they're saying is that we can use it as a holding pattern prior to commencement of chemotherapy. If there's going to be a delay in chemotherapy because the dog maybe is being referred, or we're having to order the drugs in, or for whatever reason, then this is something that we can give, and we are not going to induce resistance to chemotherapy drugs by using Laverdia, just as we might if we were using steroids. They're also saying, look, if the owner declines conventional chemotherapy, say, I can, obvious situation, my dog hates the vets. He's going to need to be sedated every time he has chemotherapy. I don't want to do that on a weekly basis. Is there anything else we can use? Well, yeah, here, we've got these drugs that can be given at home. And that's a much gentler approach. So again, that's an area where this drug might score. We do not know how it sits as a treatment, say, combined with other drugs, such as steroids, for example, or combined, given alongside conventional chemotherapy. We do know that it does cause side effects, or has the potential at least to cause side effects, such as gastrointestinal toxicity. Still need to be careful handling it at home, still need to be careful dealing with waste products from the dog, just as we would with any conventional chemotherapy. So another new drug is Tanavia, or rivaroxaban. And this also has a fairly unique method of action. It inhibits DNA synthesis. Now, that is not unique. Loads of drugs inhibit DNA synthesis, and you could argue that the majority of chemo drugs that we use inhibit DNA synthesis in one form or another. But this does it by targeting a specific enzyme called DNA synthase that is not targeted by any other chemo drug. So that's the claim for a unique method of action. It may be because DNA synthase seems to be overexpressed in lymphoma cells that this is a more specific targeting of lymphoma. I think time will tell. We need more studies to see. I mean, this is a chemo drug. It is cytotoxic. It can damage other cells. It can cause side effects, such as bone marrow suppression, vomiting, diarrhea, the things that we traditionally see with our conventional chemo drugs, we will see potentially with rivaroxaban as well. It's given IV every 3 weeks. And these are our current sort of facts and figures regarding its use. So first line treatment, I mean, it's broadly similar to what we would see with doxorubicin as a sole agent. So 73% response, 5 to 6 months progression-free interval. So that's kind of what we see with if we were using doxorubicin. So maybe not a massive benefit. But it's interesting, and this is because we use this is a novel method of action. These tumor cells that have had prior chemotherapy will not seemingly have developed a high-level resistance to Tanavia or rivaroxaban. So look what happens when we use it as a rescue treatment. 3/4 of patients respond. It's exactly the same as is used in the first-line treatment. 63% complete remission, 6-month progression-free survival. Now, these are preliminary studies. They need to be confirmed with higher studies. But if you look at that response to using this drug as a rescue versus what we're traditionally able to achieve with our other rescue therapies, I mean, this is doubling our progression-free survival. It's doubling our initial response rate. So to initially, at least, that seems to be where it's going to potentially land as offering us a real novel and potentially much more efficacious rescue. So that is where we are so far. Thank you very, very much for listening. And I am very happy to take any questions.
There's just a few in the chat, Rory. I don't know if you see them or if you want me to read them.
I can't see the chat, I'm afraid.
Okay. Well, Victoria asked earlier on in the presentation, How long does pred take to cause the decreased response rate? Would a week cause it, or is it if it's more long term? I was taught not to give any pred at all before chemo, but recently have heard it's okay to start pred a week before vincristine.
We don't really know is the answer. There are no good studies out there that show how long it takes to cause increased production of that pump. A few days, you're probably okay, is my best guess. Longer than that, and you start to potentially run into problems. But as I said, we don't know for sure, and certainly don't know in each individual patient. So, as a general rule, avoid if possible prior to starting chemotherapy.
And then Victoria's also asked, what about cats with asymptomatic cardiomyopathy having doxorubicin?
I'm pretty okay with that, because if it's a hypertrophic cardiomyopathy, then that's going to be okay, and that's probably one of the reasons why doxorubicin isn't recognized as, or doesn't have as a same role as causing cardiomyopathies in cats as it does in dogs, because what doxorubicin tends to cause is a dilated cardiomyopathy, which is the opposite of what most cats with cardiomyopathy have. Now, I would still be a little bit cautious, and in an ideal world, I would still echo a cat if I was thinking of using doxorubicin, because we do see cats that sometimes have systolic dysfunction as a consequence of microscopic myocardial infarcts. We do have cats that have cardiomyopathy characterized by transmural hypomotile segments, which tends to be quite a rapidly progressive form of cardiomyopathy. And these cardiomyopathies are associated with systolic dysfunction. So I guess because, in an ideal world, I would do an echo to rule those cats out, but because far and away the most prevalent form of cardiomyopathy in cats is a hypertrophic form, generally speaking, we worry less about the cardiotoxic effects of doxorubicin in cats than we do in dogs.
And then the last one on there is from Lottie. What considerations would you have protocol-wise for diabetic/Cushing's/Addisonian patients?
So for diabetics, definitely it's a conversation to have, because we do have an increased risk of prednisolone causing insulin resistance. Generally speaking, I would, if the owners are up for treatment, I would still go with a high dose of prednisolone. I would ask the owners to monitor at least urine glucose and keep a close eye on that for development of any ketones. But remembering that we are going to be tapering off the prednisolone quite quickly over the first month of treatment. And it is pretty important in terms of trying to get a tumor into remission in the first place, which we need to achieve if the animal is going to have any sort of hope of a long-term future. So I would still go with prednisolone. For diabetes, for Addison's and Cushingoid patients, I'm less concerned, because provided they're well controlled in response to trilostane therapy for the Cushingoid patients, yes, they're going to see the same sort of iatrogenic Cushingoid effects as we're going to see if we give prednisolone at the same dose to an otherwise healthy dog, but it shouldn't be any worse. Addisonian patients, you can argue that would actually benefit from a slightly higher dose of prednisolone than they're perhaps getting at what is a physiologically stressful time for them when they have cancer. So again, less of a concern. The main one is diabetes, but I think it's sort of short-term hit for potentially medium to long-term benefit.